All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound case series. Today we have Dr. Sheila Taylor. She's a primary care sports medicine physician at the Orthopedic Center, which is a partner of the University of Maryland Shore Regional Medical Center. She provides non-operative musculoskeletal care for patients of all ages and activity levels. More than half of her clinical practice is devoted to diagnostic and interventional ultrasound for both acute and chronic conditions. Prior to joining the Orthopedic Center, she was the Associate Program Director for the Sports Medicine Fellowship at Christiana Care and the team physician for the University of Delaware for several years. She completed a family medicine residency at Reading Hospital and sports medicine fellowship at Wellspan York Hospital. Dr. Taylor is going to be presenting on bicipitoradial bursitis today. All right, Taylor, you can go ahead and share your screen.
Thank you so much for having me. I'm really excited to be here, and I'm excited to tell you guys about a uncommon but interesting topic. And interesting, like you were, previously discussing, sometimes these rare things you don't see that often. And then when you do see them, one or two pop up. So I've seen it actually a couple recently. So we're going to talk today about bicipitoradial bursitis. So our objectives today, we're going to review anterior elbow anatomy. We're going to review the anterior elbow anatomy scanning protocol. We'll review both normal and pathological findings. And then we'll briefly just touch on the pathophysiology of bicipitoradial bursitis and talk about some differentials for it. And then we'll put together our ultrasound report. So we'll start first with my case. So I had a 58-year-old right-hand dominant active female with chronic left anterior elbow pain and proximal forearm pain. She described the pain as sharp and burning, as well as with some tightness, mostly with flexion, extension, supination, and pronation, but pretty much any of her normal activities. She noted occasional popping and catching with supination and pronation. Her pain was worse with any lifting activities. In the morning, she felt like her pain was not, very significant, but it worsened throughout the day, just doing her activities of daily living. And it had been ongoing and progressively worsening for about 2 to 3 years. Her treatment had been slightly delayed with COVID, and she kind of put it off, and it had been progressively worsening. She didn't note any inciting injury, trauma, fall, no radiation of pain down the arm, no prior elbow injuries. And she's a pretty healthy lady, no pertinent medical problems, social history, family history, no inflammatory arthropathy or history of gout. So her physical exam, I noted mild swelling in the antecubital fossa, no rashes, lesions, deformities. She was tender over the distal biceps tendon and in the antecubital fossa. She did have full flexion and extension, mild limitation in pronation and supination, and both of those motions reproduced her pain. She did have full strength, but pain with resisted flexion of the arm, supination, and pronation, and normal stability testing, and she was neurovascularly intact. So at this point, you start to think about your differential diagnosis. So, given the chronicity of her symptoms, thought about a partial biceps tear, biceps tendinopathy, inflammatory arthropathy, ganglion cyst, gout, and a mass or tumor, just given the swelling and the location and the palpable kind of fullness that she had there. She had x-rays that showed just mild degenerative changes of her radiocapitellar joint, but nothing significant. And then she did have an MRI about 1.5 years prior to her meeting me, because she had delay in her treatment. And so these are her MRI images. Just one slice of each, but that we can really see this pretty clearly. So in her axial image, you can see here we have that swelling and distension of the radiobicipital bursa. And then in her sagittal view, you can see it nicely in this view too. I have this little image down here that just kind of shows it, how it correlates to this axial image almost perfectly. So the classic view of radiobicipital bursitis is you're going to see this bilobed kind of U-shaped appearance of the bursa as it distends and kind of envelops the biceps tendon. And it can be misread for a lot of things. And interestingly, in our radiology report of this, they just noted, distal biceps. They actually called it like tenosynovitis. And we know there is no biceps tendon sheath in this area. We can call it peritendinous fluid, but she did have synovial thickening. And this is just another view that shows that distal biceps coming down on the radial tuberosity. We can see some tendinopathy here and a slight abnormality of the radial tuberosity. So we did do labs. So I got serum labs, which were all negative, no inflammatory arthropathy, no elevation in her uric acid. I did tap her at the time of first meeting and sent her synovial fluid. I got about 3 mLs out of the bursa. It was clear, yellow, didn't have any particulate matter. It had a normal cell count, negative for crystals and negative culture. And so, and then I, started treating her, and we'll go through the ultrasound scanning protocol through AMSSM. So I start with the anterior humeral radial joint. We also look at the anterior humeral ulnar joint. So we'll look at the joints, we'll look at the fossae. You can do a dynamic scan of the annular recess with pronation and supination as indicated, looking for any fluid or joint effusion. Most importantly for her exam, the biceps tendon and muscle. You can look at the brachialis muscle, the brachial artery and vein, and then our nerve structures. And then depending on, what you're looking for in your patient, you can go more in depth into the nerve ultrasound aspect of it. But most importantly, when you think about anterior elbow ultrasound, the anatomy of that biceps tendon will, dictates kind of how you perform the ultrasound, and it can make it a technically challenging ultrasound for new ultrasonographers. So we'll go into that a little bit. So when I start the anterior elbow ultrasound, I like to kind of have this home base. These are images from Bianchi, and you can see here, we're looking at that humeral ulnar joint. We can see the hyaline cartilage there. And this, when we're in this view, the biceps tendon is really easy to identify because it's very superficial. And then as you follow that arm distally, you can follow the biceps tendon nicely as it starts to dive deep. This is more proximal on the arm. And we can look at the biceps musculature as well as the brachialis musculature. And then to look at the joints. So when I did, during my case, I do this complete diagnostic ultrasound, but I don't often save a ton of these images just because that clogs up our imaging. But I will look at all these structures. So to identify the humeral ulnar joint from that short axis view that you had as your home base, then you're just going to rotate your probe, and then you're going to come ulnarly to find where that humerus meets the ulna. You're looking at that joint space here. You can see an effusion in this space. And then when you're looking at the humeral radial joint, same thing. So after, I think this is easier to start with actually. So from that short axis view, again, rotate your probe and you're going to identify the humerus and the radius. And you can look for distension of that joint capsule here. This is normal. So then if I go back to my case, so I started at that short axis view. This image is flipped, but we can see the brachial artery here. We can see the biceps tendon here. And as we start to go distally, that biceps tendon starts to dive. And you can already see this bursal fluid that is below the biceps tendon in this view. So then we will move to the biceps tendon itself. And this is where I think in this view, it gets a little bit challenging to identify, especially if you have a bigger person, because that biceps tendon dives deep and inserts. So you have to have I lay my patient down supine so they can fully relax with their arm extended, and you want to maximally supinate the patient's arm. And then from that short axis view as your home base, again, you're going to rotate your probe and you're going to identify that biceps tendon diving down on the radial tuberosity. But this is where you really have to heel toe your probe to be able to get that all in line, because as that biceps tendon dives into the radial tuberosity, you can have significant anisotropy as the fibers are curving away from your probe. So you're going to heel your probe kind of in towards that radial tuberosity to see if you can get a good image. And it can be challenging to get a good image in this view, but obviously with a lean patient, it's easier to do. So this is from that view. This is my case. So this is the biceps tendon as it comes and inserts on the radial tuberosity. This is only one still image. My cine loops I couldn't get easily onto my presentation, but and so in just this one snapshot, right, you could be convinced that you had maybe a partial tear or some major abnormality at the insertion of the biceps tendon. She actually didn't, but we can start to see that, or we can see the bicipital radial bursa distended underneath the biceps tendon and a slight abnormality on the radial tuberosity there. This is the pronator window view of the biceps tendon. I love this view. I think it's easy to do once you practice it enough. So this is from Smith and Finoff's article in 2010. They showed here the patient seated, but when you already have your patient supine, then you just are going to flex their arm to 90 degrees and they can comfortably lay like that. And the key to getting this view is that you want to start with your probe parallel to the humerus, far away from the biceps tendon. You're not even looking at the biceps tendon. You want to identify the humerus, and then you want to just bring your probe distally and then anterior. And as you come anterior on the forearm, you're going to see that biceps tendon come into view nicely right under the brachial artery. And naturally, you may want to, when you think about how that biceps tendon dives, you may want to come like anterior over the arm, but you want to really make sure that you avoid doing that. You want to stay on the forearm. And as you do that, again, your probe is coming straight down the humerus and coming anterior. Your probe will be perfectly positioned to visualize that biceps tendon in long axis as it inserts on the radial tuberosity, using that pronator as a window to view that. So this is normal anatomy here from their article. And then we'll pull up my images from my case. So again, I couldn't get a good cine loop on here, but these are stills in both pronation and supination. And so this is the biceps tendon as it comes and inserts on the radial tuberosity. And you can see that big descended bursa inferior to the biceps tendon. She had synovial thickening in that area. Here's another piece of it. So this is maximally supinated. And then as I pronated her, you could see again that abnormality in the radial tuberosity coming into view. And the bursa kind of changes shape here. So and that correlated with her symptoms of like feeling a mechanical pop. And this is just another view of it. I like this image because it can show how the bursa will change depending on your pronation or supination of the tendon. So you can see when you maximally pronate the tendon, that puts more stress on that bursa, and it's going to kind of form one larger collection. And then as you relax the tendon and supinate, it will go back into that bilobed appearance. I like the Cobra view as well for procedural interventions. And this allows you to see that biceps tendon inserting on the radial tuberosity here. So this, you don't have to sit your patient up. You're already laying them down. I just have them flex their arm up off of the table. And then you want to maximally pronate them to get that Cobra view. And when you pronate, you're going to, that radial tuberosity with the biceps tendon inserting on it is going to come into view nicely. And then you can supinate and you can see it goes out of view. And if there was a descendant bursa here, sometimes you can see some of that bursal tissue come into view. This is a very safe view and window to be able to do procedural intervention. So if you're doing a distal biceps peritendinous injection or bicipital radial bursa injection, the brachial artery, you're completely out of view of the brachial artery. And so it's very safe to do it. You're also very superficial depending on your patient's body habitus. So I think when you're first starting out and learning, this can be a nice way to do those interventions. So here are the views from my case. This image is reversed. So this is the ulna, this is the radius. And this is in maximal supination. And we can see again that kind of cortical irregularity or bone spur on the radial tuberosity with some bursal thickening. And then in this view, right, we can see the bursa kind of fully descend. So if you wanted to inject in this, from this view, you could easily do so, and you're in the bursa and you're far away from the artery. So just, some brief points about bicipitoradial bursitis. So it is uncommon, and it does affect people in a wide age range depending on the mechanism and pathophysiology. So younger patients tends to be more associated with the rheumatoid arthritis and calcium pyrophosphate deposition disease. But the mechanism most commonly is repetitive microtrauma resulting in mechanical friction in that biceps area. And specifically with our patient, I do think that that little bone spur and her repeated motion kind of set her up for this, because her lab work and everything was negative for any type of inflammatory arthropathy or autoimmune disease. It can present as a painful, palpable mass. So your patient may come in, and depending on how lean they are and how distended the bursa is, it will look like a mass on their arm. It can feel like a mass. And initial imaging, it can look like a big cyst. Depending on the chronicity of the bursitis, that bursa can be pretty distended, so it can look pretty significantly abnormal on their imaging. It can be so big it can restrict their motion, most commonly in pronation and supination, because of that, how the bursa wraps around the biceps tendon, it can affect their ability to fully pronate or supinate. And it can kind of look like a nerve problem due to compression of the lateral cutaneous antebrachial nerve or radial nerve. So they can have some distal nerve symptoms or complain of pain like burning. The bursa does not communicate with the joint, and so that's important to note, because if your patient has a distended bursa and also a joint effusion, you need to be looking at the joint. That may not be the only problem. And you don't want to mistake injecting that bursa as injecting the joint. For example, like that Cobra View, where you're in and around the distal biceps tendon for injection, you are not going to be into the joint from that approach. In terms of treatment, it is usually conservative. You can do physical therapy, NSAIDs, aspirating the bursa, injecting the bursa, and then in severe refractory cases, they can go on to surgical or endoscopic excision. I did aspirate and inject her. She got fantastic relief for about 3 months, but unfortunately she recently came back with recurrence, and it's bigger than it was before. So talking to my surgical colleagues about her option, but I think we are going to repeat aspirating and injecting it one more time. So crafting our ultrasound report around this. So this is just your basic, this is how I start all of my diagnostic ultrasounds. So you want a title for what body part you're imaging. I like to put the indications, any additional studies that I've looked at, and then your technique, which probe you're using. So in her case, we used a linear array transducer. And then this is just my standard. We took static and dynamic images in multiple planes, and we adjusted those images. And then the details and the body of the report. So for the most common body parts that I ultrasound, I created a standardized list rather than doing it kind of in prose and paragraph form. And for me, this was helpful, especially when I was starting out, because I could actually go back and look at my ultrasound templates and make sure before I go into my diagnostic ultrasound, what parts I need to really look at and pay attention to. And then you kind of, if you're always doing it in a standardized fashion, you don't miss anything. So for her, so I start with the joints. So we did visualize her humeral radial joint and her humeral ulnar joint, and the superficial visualized portion is sonographically normal in appearance, and no visualized articular cartilage abnormality or osteophyte, no joint effusion. Moving on to the distal biceps tendon, it was intact, but it was thickened with a loss of normal fibrillar echotexture distally consistent with tendinopathy. There's a small spur at the radial tuberosity at the insertion. There was peritendinous fluid visualized surrounding the tendon with distension, the bicipital radial bursa, and synovitis there. And dynamic scanning did have impingement of the bursa. I also looked at the brachialis muscle, which was normal. Brachioradialis muscle, normal. Her artery and vein, normal. Her nerves were normal in appearance. I did look at the fossae. They are normal, no joint bodies. And then I just kind of have a catch-all for superficial structures are normal. I always add limitations, especially when I'm doing my shoulder ultrasounds, because sometimes depending on the patient's pain, their anatomy, you could be limited by body habitus, you could be limited by patient positioning, and it's always important to note that. And then our impression, and for this case, so she had bicipitoradial bursitis and distal biceps tendinopathy. Here are my references from today's talk. And then just want to give a shout out to my previous colleagues at Christiana and UD, Cheney Stewman, Brad Sandell, Andrew Reisman. I miss you guys a lot. They were huge in kind of me starting out as a young faculty in academia, and really helped mentor me along the way. So I miss you guys and hope everybody's well. Any questions?
All right, thanks, Sheila. I'll open up if anyone has any questions to start. Otherwise, I have a couple of thoughts.
I do have one. Hi, this is Doug Hoffman. I have one question. Sheila, so when you aspirated, did you go into that short axis Cobra position to do the aspiration?
No, because I think it's hard because you only have a small like piece of the bursa visualized. So I actually, when I aspirated, and this was, tricky because obviously you want to avoid the artery. I didn't aspirate from the pronator window. I did the standard view here, and with PDI, like identified the artery, and then I came a little more radial and just found a access point that was the bursa was most superficial. I wasn't coming through the tendon and wasn't coming through, obviously it wasn't passing through the artery. So I did it that way. And from an inferior, so in line with my ultrasound probe in plane, and inferior to superior.
Yeah, that's been my experience, because when you pronate to see that tendon from that Cobra view, you're actually squeezing the bursa. Mm-hmm. And so you're actually, so then you're limiting fluid in that position. So that's been my experience as well.
Yeah, I think it's hard to aspirate, but if there wasn't a huge bursa and you weren't going to aspirate and you were just trying to put fluid in, I think that certainly could be an approach, and an easier approach or a safer approach, like for an, when you're first starting out.
All right, excellent. Thanks, Doug and Sheila. So I had a couple of thoughts. I think this was it's definitely an interesting case. Certainly, like you said, one of those things where probably doesn't come across your across your calendar a lot unless you tend to spend a lot of time on the elbow. I think one of the things that is really interesting with cases like this is the dynamic scans, and being able to see what's going on there, and that diagram is excellent. I think when you're trying to decide like what to do for these cases, I think one thing I think about a little bit is like what their range of motion is, in particular with pronation and supination, and if there's something getting stuck between the radius and the biceps tendon and causing a mass effect, you're not going to be able to get into that pronated position. So a lot of these, folks who have kind of more soft tissue changes really lose a lot of that. So kind of trying to figure out where things are from a dynamic standpoint can be helpful, because you can have these like pseudotumors, kind of these swollen synovial bursa sort of complexes that really probably won't ultimately go away with injection-based treatments, for example, versus something like this where there's a lot more kind of free fluid among the synovium. Mm-hmm. That might be a little bit more amenable to like a non-surgical treatment. As you're looking and trying to figure out, gosh, is this just bicipitoradial bursa fluid? Is there any joint fluid? I just say for anyone who's kind of getting into scanning, remember, like looking in the posterior elbow joint is a good place to look for elbow joint recess, probably a little bit better than the anterior elbow joint. And so don't forget to, don't be afraid to move around the backside, even though you're doing an anterior scan, to get those other couple of views. Other things, that can certainly, coexist or sit next to this are insertional brachialis tendinopathy. So don't forget to scan all the way, not just a muscle at the anterior elbow, the brachialis all the way down to the ulna. And then, you mentioned the spurring changes in that image on the right there. You can see that little kind of irregularity at the radial tuberosity associated with, the biceps tendinopathy and what looks to be maybe a little bit of partial thickness tearing. It's a very much like a chicken or the egg question. And, we just had a sports conference yesterday. And actually, even like the case that Dr. Hasley presented last week about the cortical irregularities over the scaphoid and the FCR, and is it an abrasive problem, or are those cortical irregularities secondary to a chronic inflammatory changes? It's hard to know. I'd be curious, some of the other folks who scan a lot, and Sheila, what you guys thoughts are on, like, is that radial tuberosity and thesophyte or irregularity a secondary change, or is that a primary problem that leads to the secondary change? That's just one question I always have when I see these kind of irregularities at the tendon insertion.
Yeah, I can give my thoughts. I think it's probably a secondary change. She probably started out with micro trauma to her biceps tendon, so with tendinopathy and then partial thickness tearing, that then kind of leads to that spurring change, rather than that spur, that abnormality causing the tendinopathic changes, which then inflame the bursa. That's my take. But again, I haven't seen a ton of these, to be honest. So in talking with my surgical colleagues about this, like, hey, what do we do if this persists? They see a lot of those spurring changes in chronic biceps, partial tearing and tendinopathy, and to go in to fix it, they said they would surgically excise the portion of the tendon that was tendinopathic and kind of clean up the radial tuberosity and tack it back down. Obviously, that's a big surgery for this problem. So they do see that a lot, but I'm curious the other ultrasonographers on the line.
Yeah, I sometimes wonder if there's like almost like a radio-ulnar impingement, maybe that could lead to some of these bony hypertrophic changes. And I don't know the answer. I don't know if this is a tendon that leads to this, or if it's radio-ulnar impingement that leads to spurring, or hypertrophic changes that leads to tendinopathy. I don't know, maybe Doug or Jake, Alex, I see you guys on here. Just curious what your thoughts are.
Yeah, I actually think this is more of a impingement. So, I have found that Cobra View, the view when pronated, from a diagnostic point of view of the distal tendon is not as helpful as the long axis view, but it's the best view to look for impingement or bony hypertrophy of the radial tuberosity. And I've had a number of cases where I've seen partial tearing, a pretty shredded up distal tendon, and talked to our elbow surgeons about this, and they all kind of shrug their shoulders and say, well, the surgery, as you mentioned, is the same as a distal biceps tear. They detach it and drill a hole through the radial tuberosity, so it's not impingent anymore, which is their standard repair anyway. So and I just want to mention from this case that I think one of our goals obviously is to come up with the cause of why someone has fluid in the bursa, and in this case, I think cause was identified, and my experience is exactly the same. That distal biceps tendon pathology, far and away in my practice, is most common cause of identifying fluid in the bursa, with all those other causes far down on the list. But if I was in a rheumatology practice, for example, those numbers may be different. Just why
I agree.
Oh yeah, go ahead, Jake. Sorry.
Oh, I was just going to say I agree with what people have said about this being an impingement problem. I mean, I'm not sure, chicken or egg as far as how the osteophytes develop, but we see the same phenomenon throughout the body at the greater troch and the Hagelin deformity and so on. And I think that when in those locations we see these undersided tears, just like we a lot of times see here at the biceps. So I think as far as how the tears develop, I think that they're probably secondary, or at least the osteophytes are contributing to those.
And to piggyback that, Jake, when I see a significant impingement, I'm less likely to consider PRP with some of these distal biceps sort of low to moderate grade tears, because I think you just need to take away the impingement, and I think PRP is not going to solve that problem.
Hey, Doug, could you just elaborate when you say when you see the impingement, could you talk about what you're seeing with that and what clues you would have that like that would be the case? Is it just osteophytes? Is it the dynamic Cobra view? How do you assess that?
So for me, at least, it's a dynamic Cobra view where I'm seeing, and I don't have a number, and I don't know if a number's been validated as normal or not normal, but if I see bony hypertrophy and very little space on that Cobra view when I'm pronating and supinating, then I'm qualitatively saying that there's impingement.
And you're saying space between the radius and ulna there?
Correct. Between
Yeah.
the radial
Yeah.
tuberosity and the ulna.
Yeah.
Yep, exactly. Just a couple quick other comments. Sheila, nice job. And I don't really have anything new that you didn't say. I do want to highlight a couple points though, because I think they're important. So you mentioned home base, and I love that term. I love that term home base because so many exams, I think we need to have a foundation of where to start. And so that is my home base. That is my first image in the anterior elbow protocol. In fact, it's my first image in any elbow protocol that I have. But the thing I like about that home base in reference to the distal biceps is oftentimes you see the pathology right away on that short axis. So when I'm at that home base that you described, the first thing I do is scan proximally until I see that central tendon in the biceps. And I can tell right away if there's a rupture or not. And then as you get back to the home base and start to scan distally, oftentimes you can see the biceps pathology if it's not ruptured, but you have partial tearing or you have tendinosis. And so I'm with you on that. And I love that home base. A couple of things in that home base. Again, you mentioned the lateral interbrachial cutaneous nerve. So that's something that I do look at with distal biceps abnormalities, because it can come in play, and there's reported cases of compression with bicipitoradial bursopathy. And then also the recurrent radial artery is not something I normally look at unless I'm going to do an aspiration or an injection. And so if I'm going to do any type of procedure involving the distal biceps tendon, then I need to identify the recurrent radial artery. And I think, you know, the only other thing I had, what I was going to say is that Cobra position, again, is where I see impingement. But in terms of just diagnosing distal bicep tendon itself pathology, I find that the long axis images are much more helpful.
All right, fantastic. Thank you, Sheila and Doug. Anyone else have any questions or comments? All right, sounds good. Well, we will end it there. Just as a reminder to everyone, we're back in a couple of weeks on September 1st. Dr. Ben Badoun is going to be presenting on iliopsoas bursitis. So we'll see you guys back in a few weeks.
All right, thank you.